This is Eric Barnes, obviously with the Daily Memphian. Thanks to those who have joined us. We are still waiting on Dr. Threlkeld. He's obviously very, very busy at this moment, but we will get started as soon as he's on. A number of people have emailed me questions at it's barnes@dailymemphian.com. That's great. And you can go on Facebook. If you follow the link on the site, you can go to Facebook or Twitter and post questions there, and I'll try to juggle all this and get to those as well. So we will get started as soon as we get, I think we're close. Something is happening. The magic of Zoom.
Asking her something, I'm like, come out of this corner. I'll see you later.
Yes, ma'am. Good to see you.
Hey, how are you all? You're
Doing
live.
well.
You are live. Would you like me to mute you? Or are you ready to go? Hey, Dr. Threlkeld, how are you? I'm great.
You need a
We're
minute
good.
or
We're
two?
good.
You're good?
Okay. Thank you for doing this.
You bet. My pleasure.
We are live, so we're doing this on a YouTube live. So I'll try not to swear, and we'll get through this together.
I'll try not to make you swear, so we'll be even.
No, you got more to swear about than me, that's for sure. Thank you again for doing this in your busy schedule. We've started to get some questions, but they relate in some ways to the, I think one of the last times I saw you was at the kind of public party we had, street party we had for the Daily Memphian.
Yes.
Ran into with a mutual friend.
Exactly.
And there were, I don't know, a couple hundred people there in the plaza at Overton Square. And that seems like such a foreign experience after a month of social distancing and shut down in public. Yeah. Do you have a sense of where we are relative to when we get back to those sorts of public gatherings?
Yeah. Well, let me say anecdotally, some of that may become part of our DNA. I remember I had a great aunt who nearly died at the 1918 influenza virus, and she had family come home from the war because they thought she was going to not make it. But she recovered, and she remembers distinctly that it took 2 or 3 years for people to want to have large family gatherings and even weddings. And so that became part of their DNA. So it may be that no matter what restrictions are put on people, they may not be as comfortable going to a sporting event and sitting next to a bunch of people in a close proximity. So we'll see. That remains to be seen. In terms of the peak right now, we obviously don't know, but the now nearly cliche verbiage of blunting the curve, we hope that, this is the peak, that we're going to experience an increased number of cases, but that we won't let it reach kind of an Everest type peak, that they've seen, unfortunately, in New York and to a lesser degree in New Orleans and other places. So we hope that we prevent that kind of peak, but that we kind of keep it at a lower level, in which case it could be just it stays at a lower level for a longer time. But it's also the reason that we have to work very hard to do the social distancing, not just do it, but do it very properly and aggressively, because if people are cheating and it keeps it going just enough to have the virus continue to smolder and have pockets where it could come back at us, then you have more of a likelihood of it coming back when you pull back from those larger restrictions. And we'd like to obviously come as close to getting rid of it in the vicinity of the city as best we can completely.
Does the fact that we have not hit a peak, or that not that we haven't hit a peak, that we have not flooded the hospitals, that we've not had that really awful situation that New York has had, New Orleans, does that then, does it worry you that then causes people to soften on the distancing? That they're like, hey, this isn't all that necessary, we're fine. I'm gonna go out, I'm gonna hang out with friends, I'm gonna go do whatever.
Absolutely. I mean, as I say, I seemingly criticize models maybe more than I should, and I don't mean that. I know that we have to be careful because the models mean nothing more than a representation of what human behavior is doing. And the minute we see that models are improving, and it looks like, gosh, we're going to be better off, that does have, I think, a tendency to have people say, aha, so I can take the whole family shopping tomorrow instead. And then you look up and see that we have a D+ or D-, depending on where you look, at our social distancing effectiveness. Those two things they wrestle with each other, and we won't know the outcome of our potential D- if that's true until a couple of weeks. You have to have time to transmit the virus, for the time to get sick and be sick enough to be in a hospital. So 2-3 weeks from now, our being a bit lax because the mouse could transmit into or translate into a lot of new hospitalizations. And that's what we have to work very hard to avoid for just the reasons that you mentioned.
Yeah, and this week we had Mayor Strickland on Behind the Headlines, which I think is actually already posted on our site, but normally airs on Thursday. And he talked about people need to ignore the University of Washington model that talked about a peak this week. He said, we're looking at mid-May and beyond. I mean, there's a very cautionary message, which I think it sounds like you have as well, and it moves every day. It would seem though that one of those main issues in determining when we can get out there, and then once we begin to reopen as a city, let alone a country, it's testing. And if I'm not mistaken, and you're obviously going to correct me if I'm wrong, the countries and areas that have done it really well, I think Iceland's an example, and South Korea, they had mass availability of testing so that you could find the people real quickly, you could rule out problems real quickly. Is that necessary to reopen, whatever that means, to begin the reopening of Memphis? Is mass testing a necessity for that?
Well, it may not be completely necessary, but it's certainly advisable in my estimation. I think to be able to do that in a completely informed and more scientific fashion, we have to know how much virus is here and where it is. And that obviously makes us a lot smarter at how, we may find that we back off of some of the distancing and then we have a resurgence of the virus. That's possible. A lot of people have cautioned against that. If that does happen, our having adequate testing and the data from those adequate testing may then allow us to, rather than have the knee-jerk complete closure of everything again, it may allow us to be a bit more surgical in what we're doing and say, well, this sort of thing needs to be closed and this sort of thing, rather than just close the door entirely. So I think, yes, testing is going to be crucial. The combination of the PCR testing and the serology or antibody testing. And I know the Baptist system is about to embark on a very ambitious testing program for most of the healthcare workers and many patients to try to identify specific clinics and places where we know they are virus free. Some people are immune. We'll be able to direct people to the safest place, safest both in terms of the healthcare workers and the patients. And I think that needs to be expanded to the city at large, to be sure.
How, I don't even know how to ask the question, but I'll ask it in a dumb way. How many tests do we need per day to be effective? And when do we get that?
That's a tough one. And I just honestly don't know the answer. I think we're far enough away from it where I would tell you more than we have now. But what that magic number would be, I'm honestly not sure. I think the more we get, the better we can do. If you look at that small town in northern Italy that was, the surrounding areas were suffering and it was on their way to them, and they essentially tested everybody in their town and they found a few positives, and they put the net around those situations. They did sort of high quality testing of contacts. They got everybody into quarantine that needed to be, and they retested a short time later, and guess what? It was all gone. Now that's a dramatic example. It's a smaller place. It's less ambitious than larger cities, but I think it goes to show us that the closer we can come to that sort of, utopian model of how to do it, the better chance we have of scientifically kind of tossing this thing out of the community completely.
Where do the tests, there's this kind, everyone, one way or another saying, not everyone, but the experts one way or another saying more testing. Business community is saying that was something that apparently President Trump heard from his business roundtable, business group, advisory group, whatever it is. You got to have more testing before their businesses are comfortable bringing everybody back to work. Where do those tests come from? I mean, who are you looking to as a hospital to provide those tests? Is it private clinics? Is it the CDC? Is it FEMA? Is it yourself? I mean, where do those tests come from to get us to that critical mass?
Yeah, so we had, just from a logistics standpoint, a relationship with a combined microbiology lab effort with American Esoteric Laboratories, which turned out to be an outstanding partner because they can crank out 5,000 tests per day for us right now. And so as you, I think, has been reported, in Daily Memphian, maybe even today or yesterday, that, that we're now finding that maybe we have more tests available than we have people motivated to come get them at the moment. And so we have to have both. We have to have the tests available. Before we had that, you can't embark on any kind of big program to test everybody if you don't have the tests. Once you do, you have to coordinate that testing in some sort of strategic fashion, both in motivating people to get tested and in doing the test. So I think they have to come from, I think with our system, it's going to come from the clinics and the hospital, both. The idea, it's easier kind of in one system because we're trying to find places people can come to safely for their elective or urgent health care. It's a little bit harder, obviously, when you're looking at entire towns or cities, but you have to have a strategy of how to do that, I think.
Yeah, and again, Mayor Strickland talked, and we may have written about it today. I mean, there's a time warp for all of us, so bear with, about some more mobile testing going into Fraser, going into some underserved neighborhoods. But a number of the questions we got that people have emailed me are about testing. And one person said, when will testing be available for people who don't have symptoms, but maybe have an underlying condition that makes them very much at risk if they get it? Is that sort of testing available for people now?
Theoretically, yes. I mean, whether it's available at various sites in the city, I'm not as certain about. Certainly, we're doing some testing and have done a fair amount of testing of asymptomatic individuals. I mentioned yesterday that we looked at, I'm trying to think of the total number now, but a fairly large number into the hundreds of healthcare workers, both frontline healthcare workers and support staff, and we found a positive rate of about 2%. We also, interestingly, looked at asymptomatic individuals coming to the hospital. I say asymptomatic with respect to COVID-19. They may have had a urinary tract infection, some infection of their arm, that kind of thing. But we tested 61 of those, and interestingly, 0 of those 61 people tested positive for COVID-19. So that's both encouraging, but also it tells us that we need to take advantage of the kind of the blessings that we've been given of being farther down the road in this infection. New York, New Orleans, they were hit harder earlier. They had a hard time getting their feet on the ground. We have that advantage in that we've been able to do some of our social endeavors sooner, before the virus was really circulating in a large amount in our city. And we're also not stacked on top of one another like they really are in New York. It's an easier thing to do in that sense.
If someone is, and then you can't diagnose or give recommendations in a specific way, but if someone is they are concerned, they've got an underlying condition, they've got serious asthma, someone here mentions an autoimmune disorder, do they start by calling their doctor to line up a test? Again, somebody who's asymptomatic, or if they don't have a doctor, do they make contact with a Christ Community or a Church Health or one of the clinics?
I think both of those answers are correct. If you have one of those autoimmune syndromes and so forth, and you're in care for those things, you're likely to have some contact with a physician, and it's great to check with those. We certainly, I know the testing center we have here used to be an extension of the emergency department. It is no longer, as the situation has morphed. You can come by and be tested without just at the cost of the test. And yes, Christ Community and other places have some testing centers too. I think it's helpful though, if you have a doctor, to touch base with them, and they can help you kind of navigate to the right place. And I think, again, as you said a couple minutes ago, the WHO chief was probably the first to beat the drum, testing. And that's how we know who's had it. That's how we know who has it now. And that's how we know who we need to continue to protect.
Going forward, a question again, I'm going to run through, I probably have 10 questions. We may not get to all of them, but I'll try to group them together.
Sure.
One person asked, kind of looking a little bit forward, if somebody if they test the presence of antibodies, does that assure them that they can go out, they can dance, they can drink, they can be in public, they can do whatever they want? Or even if you test for the presence of antibodies, do you still need to be careful?
Yeah, I think that's a very, very difficult question. And the simple reality of that is that it's a new virus. And unlike, we know that if you get measles, you're good forever. Anybody born before 1957 doesn't need a vaccine because it's essentially lifelong, high quality antibody protection. We don't know that completely on SARS-CoV-2. And the reason there's some question about it is that a couple of the other related coronaviruses don't cause serious infections, they cause common colds. And as close to a year or two out, certainly by 3 years, that immunity can wane. And so we don't know yet where SARS-CoV-2 is going to fit into that. So I would say we fully expect you to be protected in the short term and probably out to a year or two, such as if it came around next year, you'd have a blunted at worst kind of infection. But I would say it still makes sense to do those things that we know work. I mean, I think you probably still ought to not get virus on you that then you could touch somebody. If you touch something with virus, you could then still touch something else that someone else could be infected by. So you could still be potentially a vector for someone else's infection, even though you wouldn't get reinfected yourself that soon afterward.
A question about potential underreporting of the death rate, and New York, and I think some other areas have come out with this, where they've looked back at certain deaths that have happened and realized, believe that those people died of COVID-19, even though they were never tested positive, but just everything in hindsight, layman's terms, looked like they had died from COVID. And it was a big spike, a big jump in their numbers as a result of that. Do you have any sense yet whether that is happening in the Memphis area, that there is an underreporting of deaths of COVID infected people?
I would say this. I think probably as the time goes by here, and we're later in the scope than New York was, which is to our advantage in several ways, as we mentioned. I think the index of suspicion has become. We've gotten so aggressive at testing people. I don't think we're missing as many people with COVID-19 syndrome as people were early on. I think we're testing a lot of people. And I see people that are tested in the hospital, and I say to myself, this person can't possibly have COVID-19. Every now and then you're even surprised, but I think if we're making an error, and I won't even call it an error, I think we're being very aggressive about testing people, and that's great. I think that's a good thing, because I think the false positive rate for our test right now is actually extremely low if you extrapolate from other known PCR tests that we've had in the past, at least in the most recent kind of iteration of that test. So I think probably less so in Memphis right now than they probably experienced a while back in New York. And I think probably the death rate, though obviously crucial, is less informative of what we need to be doing than is the case rate. And that, I think, just because so few people actually by percentages die of this infection, that it's, those that they might have missed probably won't have a great deal of impact on the case rate. And therefore, kind of how we would adjust our behavior to try to get rid of this virus.
That's great, and kind of hits a bunch of things that people are asking about. Another theme in questions here, and it's obviously a huge topic of conversation nationally and locally. We talked to Mayor Strickland about it. The governor, I think later, will have some comments on this. Is the notion of reopening? Reopening, I think, most of the government officials, most experts like yourself have talked about. It isn't flipping a switch. We don't go back to normal, but we phase it in. For you, the kinds of criteria you look at for, I assume it's the case rate in terms of judging how we can be reopening, but are there, again, public spaces, sporting events, certain things that are going to lag? What are those things that will be probably the first to open as you look at the situation?
Yeah. Well, I think what I hope is the first to open is healthcare itself. I mean, we've seen people who are, we've essentially almost all healthcare facilities have canceled so-called elective procedures. Well, one person's elective procedure is somebody else's urgent procedure. There's a line that blurs in there. So someone's, disc surgery that they need to have on their back is easier on somebody who has a bit of nagging pain versus somebody who can't walk because of that. Neither are life-threatening, but we need to get to the point as soon as we can to be able to deliver that care. And that's what I was kind of referring to in looking at clinics and healthcare workers and patients. We need to get to the point where we know that that's a safer environment to do that in. And I think that's something we need to push at soon, because we don't want the delayed elective procedures to become urgent procedures because we couldn't get them done. So that's been a priority, I know, for us, and I think will be a priority for everybody. And as important as obviously sporting events are, I'm a big sports fan, but that's going to probably, I agree, be a bit later in terms of starting with more limited things, as you say.
Would you foresee, certain types of businesses, manufacturing, broadly manufacturing? In Memphis, it might be distribution centers. Many of those are already open. But do you see more requirements put on businesses where workers are working in close proximity, so that there's a mask requirement and there's ongoing glove requirements. I mean, are those just going to be part of normal life for some months after we, quote, reopen?
I think it very well may be, with the caveat that the data behind masks and gloves are extremely weak in all directions. I mean, how exactly to do that and deploy it is, experts argue over that dramatically, of the virology of it and as well as the epidemiology of it. And you'll see people going back and forth on that. So I think that will be true, but I think it will have to be a bit arbitrary. It's difficult not to make it that way. So, and that sort of leads to frustration. I mean, obviously you see people say, well, we just need to reopen. And the frustration builds on that, but you have to realize that if we reopen and we don't take the proper precautions, such as we can figure what they are, and that's not a trivial point, and we have a resurgence of this virus and people die because of it, that's a bad problem. And we have to, and again, all of this is a circular kind of situation that comes back to as much testing as we can do to make it as informed a decision as we can as to when and how to open those things.
And is there also, and I don't mean this in a callous way, but it's a question someone asked, and I've had it asked of me and discussed and so on. Is there a certain level of risk that at some point we just have to accept, right? I mean, we live with a certain level of risk with driving, with certain environmental conditions, with certain diabetes and certain food choices. Does this at some point fall into an acceptable level of risk for our society?
Well, as you say, risk is indeed a fact of life. And if you take a certain risk in driving to work, it certainly follows that eventually we will make a decision as a society and individually, which you can still make by not going to work, right? You may decide that even if the city opens, you're not open. And so, yes, I think at some point we both collectively and individually will have to say, you know what, there's risk here, but it's no more risk than other risks that I take all the time in my life. And so it's probably reasonable to put that behind us and try to move forward. Yeah, absolutely. I think so.
One place of great public gathering that is not, I mean, again, I'm a sports fan too, but that's not important. I'm a music fan and that's not important right now. It's important to the people, the musicians and such, but schools are important, right? And there have certainly been mixed results in terms of online learning. And I think you see more, in the public schools where there isn't as much availability of Wi-Fi and broadband for people working from home. Kids, little kids, people I'm sure who have little kids at home, it's pretty hard to keep them focused for 6, 7, 8 hours a day. So forgetting college maybe, but the public and private schools, K through 7, 8, 9, 10, how and when would they be able to reopen, and what sort of restrictions might have to be put on them?
Yeah, that's tough. There's just a lot of aspects to that. I've certainly talked to many kind of heads of school about these kind of things as this was ramping up, and unfortunately it's kind of ended with the termination of the school year. So we hope that there'll be a bit of a buffer zone for us to have a bit better information under our belt to be able to make those determinations eventually. But as you say, you certainly hope that that'll be one of those things that will open up early on as I think essential in a lot of ways to a lot of people in a lot of settings. And schools make for an interesting collection of issues and problems. Kids by and large don't get sick from this virus. You will occasionally see someone get very ill, but it's quite the exception. However, a lot of them can get it and then pass it asymptomatically on to family members. So there again, it comes back to testing to know kind of where that does. And so you might see a lot of testing involved with limited opening of schools. And hopefully, by the end of the summer, we'll have made enough progress in all of those parameters where we'll feel a little bit more comfortable, maybe with some ways to spread out the students a bit more. You could envision something like that. So I hope just the time that we have bought in this situation will allow us to be smarter and be able to sort of arrive at some solutions to allow that to happen.
To that end, you see in some other countries, maybe in the United States too, but I mean pretty aggressively in some other countries that got hit by the virus first, is temperature checks at going into public spaces. I mean, is that something that we might see at schools, at grocery stores, at all kinds of necessary public spaces for the foreseeable future?
Oh yeah, no, I think certainly that could be the case. As long as we realize the caveats, I mean, kids are less likely to be symptomatic at all, so it probably would be a bit less effective in a school setting. It would, there are those kind of problems. There's also the fact that you might be contagious for a day or two before you get completely symptomatic. So there'll be some limitations with that. It could be that there would be longitudinal repetitive testing of students, just nasal swabs. Everybody gets. I'm just talking out loud, just giving examples. But it could be that before we start school, everybody gets a serology, so you know who's had it and who hasn't. And then the people who haven't, they get periodic nasal swabs to check and see if they get it asymptomatically, and that allows us to not only make the school a safer environment, but it prevents the kids that might be asymptomatically infected from going back home and infecting grandparents. And so that there would be a lot of advantages to that sort of process.
And to clarify, and someone asked this question, I can't say the word, asymptomatic means you're infected, you've got COVID-19, but for whatever reason that we still don't understand, you're not showing much, if any, symptoms, but you're totally able to infect other people. And that may pass through you, you come out on the other end and you're fine, but you are a vector. You are somebody who can infect other people, even though you're not showing symptoms.
That's correct. And
Okay.
there are a couple of things. There's the incubation period when you may have been exposed, and for 2 to 14 days, that virus is percolating in you and has not really done anything to cause you to be ill. And maybe it never will, but it may be that on average, day 5 to 8, you become sick. And so it's quite complicated. You wouldn't be transmitting the virus on day 3 if you become sick on day 9. But by the time you get sick, and probably for a day or two before, then you would potentially transmit the virus. And yes, even if you never develop symptoms during that time frame of day 8 through 2 weeks thereafter, we don't really know those numbers yet. Yes, you could give it to someone else just as much as if you had been sick yourself, probably. Now, maybe you shed less virus if you're not sick. And those are all parameters that we still have to study and know. But for now, we certainly need to presume that you could transmit it as easily as anybody else could.
Last question, because I know you do have to go real quickly here, but as of right now, is Baptist Hospital, are the other hospitals overwhelmed? Are they still have a fair amount of space in terms of ICU, personal protective gear, ventilators, and so on?
Absolutely. I don't think there's any tension anywhere that I know of in the city at this point. I mean, people have planned for this. We were planning for this when we saw it playing out internationally. We certainly have been planning as soon as it hit the U.S. We have a lot of open beds. As I mentioned, a lot of the elective services going on in hospitals are not happening now. So there are many hundreds of beds in the city that would normally be full that are now empty, that could be converted to COVID care. I mean, we've taken entire floors of our hospital and made them negative pressure airflow. So I think right now, if we do the things we need to do, there's every chance that we will never get in any sort of stress situation. Obviously, we do those things to try to minimize the use of personal protective equipment and try to keep it that way. But for the foreseeable future, I think we're good. We just need to do those things to prevent those peaks that we talk about, because that's the sort of thing that could get any city, including ours, stressed.
Well, again, thank you so much, Dr. Threlkeld. Really appreciate it, and appreciate that you've been so available to all the media. Chris Harrington was able to walk around with you and some of your staff and do a kind of bird's eye view of what's going on in the hospital. People haven't read it; they really should. I thought it was a real calming, in some ways, article about the professionalism and the sense of control that you all have over what's going on, and hopefully it stays that way. So thank you so much for being here. I really appreciate you joining us.
Thanks, sir. Appreciate it very much. Nice to talk to you.
That is the end of this first ever live extra podcast. I don't think I said that at the beginning, but that's what this was meant to be. We appreciate you joining us very much. If you came in late, the whole recording will be available later today on YouTube or as a podcast on iTunes, Spotify, wherever you get your podcasts. It'll be an extra podcast. A note that the extra podcast is brought to you by FedEx Possibilities, what we deliver by delivering. And also note that we have other weekly podcasts going on. Behind the Headlines is now a podcast available in all the places you get a podcast, as well as Bill Dree is doing his politics podcast, very COVID focused right now, obviously. Jennifer Biggs is still doing hers, podcast focused on food and other options, even though many of the restaurants are certainly closed to the public, but they are doing takeout and cooking and so on. Thank you very much for joining us. And again, join us again for the next extra.